So we'll be taking a presentation on heart failure. Operation, show your notebook. Your notebook. Your biro. Please welcome your neighbor. Welcome tonight, Abuja Cardiovascular Symposium. My sister, you are not welcoming your neighbor because you don't have one. You can still shake that man. Shake him again, please. Okay, thank you. Okay, can I have my slide? Okay. Okay, my name is Dr. Taiwo, so we'll be discussing heart failure, the diagnosis, management, and follow-up. Okay, I work with Cardiocare Multi-Specialty Hospital, a National Center of Cardiovascular Disease, a National Center of Excellence in Cardiovascular Care. Everyone does not need to go abroad for advanced cardiovascular health care. We are right here at your doorstep. Okay, so our heartline: what, why, how, and when. So what is it? Why should we care? How we recognize and evaluate and appropriate care. I'm sure a lot of us have managed heart failure in our various clinical settings. So this time we are going to demystify heart failure. So case 1, 52-year-old banker while at church, couldn't complete Jumat prayer, complained of generalized tiredness and needing to go and sit outside. Hello, anything? What happened? Sorry? Okay, sorry. Both Juma prayer and church, they are the same. It's to pray, Abi? Just ignore. We all know what it means. At least he went to pray. So, he's a banker. He couldn't complete Juma prayer, and he complained of generalized tiredness and needing to go and sit outside for her. He says that he's not a known hypertensive, but his BP has been around 147, 180 on different occasions. From our last lecture from Dr. Inuwa, is he hypertensive? He has moved his bedroom downstairs in his duplex because it's easier for him. Went to hospital and told it's pneumonia and work stress. Suffered a cardiac arrest and the next day in the office. So what do we think of this case? Is it heart failure or it's just work stress related? Heart failure. Thank you. Okay, this is a common phenomenon in which patients will present to the hospital. They will tell them it's stress, you just need to rest. So please, after this lecture, when you see symptoms like this, don't tell them to rest. It's not just rest that they need. They need proper investigation and treatment. Okay, so what is heart failure? It is a chronic progressive neurohormonal syndrome and is due to structural and functional abnormality of the heart. It's characterized by inadequate cardiac output and or elevated intracardiac pressure. The clinical features include breathlessness, fatigue, sign of fluid congestion. It's due to structural and functional abnormality. Structural and functional abnormality, meaning that the heart can get enlarged. Then the functional abnormality is the ability of the heart to contract and to fill up the blood, abnormality of filling up the blood or even ejecting the blood. And then this is characterized by inadequate output, and then patient present with clinical features of breathlessness, fatigue, and clinical sign of fluid congestion, which can manifest as either leg swelling or rales in the lungs. So let's go back to this case. He moved his bedroom. He has moved his bedroom downstairs in his duplex because it's easier for him. So what do you think is happening at that time? Sorry, I didn't hear. Okay, possibly because of exertional dyspnea, difficulty in climbing stairs. Okay, and then he went to hospital and told that he was pneumonia. I'm sure the doctors that saw probably got some findings in the chest, and then they said it's pneumonia. Okay, and then suffered a cardiac arrest the next day. So these are the complications of heart failure. They can either present with features of sudden cardiac arrest as a result of ventricular arrhythmias or features of hypoperfusion. Okay. Okay, it is a major growing health problem worldwide, affecting 64.3 million people globally. Epidemiology varies widely within and between countries. From the Interhouse study done by one of our Professor Karaye, across five countries in sub-Saharan Africa, it was found that hypertensive heart disease was the leading cause, and then ischemic heart disease was found to be common in South Africa and Sudan. It's usually a big burden. Hypertension is the driver of most of this cardiovascular disease. 30 to 40% of patients die within 1 year of diagnosis, reason why we must get it right in this night Abuja Cardiovascular Symposium. And then after diagnosis, 60 to 70% die within 5 years, mainly from worsening heart failure or sudden cardiac event, just like the banker that we presented. Patients with NYHA class 4 tend to have poorer prognosis. 10 to 70% of them have annual mortality rate, while patients with NYHA class 1, well, mortality rate is still there, about 5 to 10%. Functional status, meaning NYHA class 1 to 4, is an important predictor of patient outcome. Like I said, patients with NYHA class 4 have poorer prognosis. So how does it occur? It occurs as a result of imbalance between the three key neurohormonal systems: the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the natriuretic peptide system. The renin-angiotensin-aldosterone system actually is responsible for fluid and water retention to restore the cardiac output. Okay, the function is to restore this normal cardiac output at short term, but persistent activation of this has a deleterious effect and we worsen patients' symptoms. The sympathetic nervous system also is responsible for increasing myocardial contractility to help to increase myocardial contractility so that the heart will be able to contract and pump out blood as appropriate, to meet the demand of the body. That the natriuretic peptide, this system is put in place to counteract the effect of the renin-angiotensin and the sympathetic nervous system. So NT-proBNP, natriuretic peptide system, has a vasodilatory effect, while others has vasoconstrictive effect. So in heart failure, this NT-proBNP is usually elevated. We will see the importance as we go on in the presentation. Like stated in this slide, it has a protective effect and then can counteract this detrimental effect. It is a vicious cycle. It started most times by myocardial injury. This myocardial injury can either be acute onset in case of MI or an insidious onset in case of pressure, like in case of hypertension. So what happens is when this happens, so there will be activation of this neurohormonal imbalance. The neurohormonal imbalance, like I said, is a way of restoring the myocardiac output that has been reduced as a result of this insightful cardiac event. So this now leads to electrical instability. The electrical instability is as a result of loss of myocyte death, myocyte hypertrophy, myocyte ischemia, myocyte death. All this lead to ventricular remodeling. So when we do echo and you see ventricular remodeling in the patient, it's not something you just say, don't worry, just ventricular remodeling. Patient should be treated. Ventricular remodeling it tends to be progressive in case of heart failure, and then the aim of treatment, the goal of therapy, is to blunt this ventricular remodeling because it's a vicious cycle. As time goes on, it will get worse. So the cardiac dysfunction now manifests as either systolic, in which there is inability of the heart to contract and pump out adequate blood to meet the demand of the heart, or abnormality of filling the left ventricle so that blood can be in the system, or it can be both. So pathophysiology, it is a progressive disorder. Like I said, it is initiated after an index event. This index event is a progressive. Sorry, I'm not getting this. Okay. Sorry, I have a problem with the pointer. But let's look at the slide. The index event can be in case of myocardial infarction or hypertension. So when this happens, okay, so press it down for long. Okay. So the index event. Okay, the index event can either be hypertension or myocardial infarction. So when it occurs, the compensatory mechanism are put in place, the activation of renin-angiotensin-aldosterone system, the sympathetic nervous system, and then the aim of this is to make sure that they restore the cardiac output to normal level. Okay, and then at that time, sorry. Okay, please just follow me. As at that time, the patient remained asymptomatic, the ejection fraction can be normal. But this compensatory mechanism will continue to occur. When it continues to occur, so the heart gets more damaged and then cause a secondary damage, and then patient can be symptomatic afterward. Initially, when this compensatory mechanism are put in place, patient remain asymptomatic. Ejection fraction can be normal. But with the progressive activation of these systems, it further damages the heart and then further worsen the symptoms, and then patient can become asymptomatic. Like I said, these events can be abstract in case of MIP. It can be gradual or insidious onset, and it can be hereditary. So what causes heart failure? So many etiology, but the driver of it all is the hypertension. Like from our data and published data in Cardiocare, hypertension is the leading cause, just like the finding from the Interheart study. And then even sub-Saharan Africa, it was found that in South Africa and Asia, ischemic heart disease was found to be the topmost, but then they still found hypertension as 43 to 9%. Various etiology, like I said, but hypertension is the driver of most of it all. Arrhythmia can cause heart failure, like atrial flutter fibrillation, ventricular tachycardia, myocardial disease, valvular disease, mitral regurgitation, tricuspid regurgitation, pulmonary regurg, pulmonary valvular disease, volume overload. All these can cause heart failure. So please, I want to put it up to us. In our clinical practice, which etiology have you been able to elicit, please? Which etiology of all these? Hypertension, okay. Apart from hypertension, which other one? Hypertension is still the leading cause. Okay, so how do we recognize and diagnose heart failure in our practice? Okay, the symptoms include shortness of breath, leg swelling as a result of congestion, sudden weight gain. Patient can tell you that, okay, they are increasing in weight, but rather, when you look critically, is fluid retention. They can have sudden fatigue or weakness, and they can have chest pain. So these are the clinical manifestations. Dyspnea, autopnea, paroxysmal notional dyspnea, cough, reduced urine output, tachycardia. Autopnea is dyspnea when they assume a recumbent position. And this is a result of the distribution of fluid from the splenic area, from the leg, into the central circulation. So when they assume a recumbent position, they tend to have difficulty in breathing in that position. So while paroxysmal notional dyspnea can occur after like 1 to 3 hours when they assume recurrent position. So patients tend to have, for autopnea, patient can present with cough. They can tell you, okay, anytime they have nocturnal cough. That's the commonest presentation of autopnea, apart from, okay, difficulty in lying down because of shortness of breath. Nocturnal cough is one of the presentation. So when you see patients with hypertension complaining of nocturnal cough, and then you examine, you pick pedal swelling, that patient may likely have heart failure. So on examination, patient can have pedal swelling, they can have thorax and they can have jugular venous elevation and all. So you want to say something?
So just to reemphasize, we've said heart failure, predominant symptoms are getting tired easily, right? Getting tired easily, 1. 2, congestion, leg swelling, tummy swelling, okay? Predominant swellings. Number 3, difficulty in breathing when they lie flat. Some people will tell you that unless they go to their window, they cannot sleep. It's not the window, it's the sitting up. Okay? So anytime you have a patient, especially those with a condition like hypertension, telling you that they are getting tired easily, you need to think of heart failure. Again, you need, like the example we gave here, somebody can no longer complete their Jumat prayer. Somebody is unable to do certain things. That person is already telling you, I am getting to heart failure. And if you don't treat them, you will lose them. The problem is that a lot of patients with heart failure are coming 2 years too late before they can actually start getting the appropriate treatment. So you need to recognize them very well. So again and again, it's very important. Please, this TV is about to go off. It's very important that you pay attention. Number 1, there's a risk. There is something that damages the heart. Number 2, it presents in this manner. Number 3 is that it is chronic and progressive. Remember, she showed you that slide. It is invariably progressive towards death. So if you don't do anything, that person is going to die. And the treatment is for life. And the treatment is manifold. So that's what we're talking about. So for those of you at the back that were looking a little bit confused, I just thought I should re-emphasize that. Is there any question? Anybody that has a burning question, you don't understand something so far?
Any question?
You don't understand something so far that we need to talk about briefly? Fantastic.
Okay, so when they present to us, it's always good to know what the cause is, because we are going to address, that should be addressed. Like hypertension, if they come, if the risk for that heart failure is hypertension, you need to treat the hypertension. If the risk is alcohol, we've seen some patients with alcoholic cardiomyopathy, you need to tell them to stop alcohol. If it's COPD, you need to treat. If it's structural pathology, you need to treat. Congenital disease, chemical disease, they can present with angina, MI. Luckily, we have Cardiocare with us. You can send your guests to us. We quickly take your patient to cath lab and they open up the vessel. Inflammatory condition like pericarditis and all. So history is always, it's also good to know what is causing, what is tilting them to develop this heart failure, this history of precipitants. If it's infection, you need to treat this infection. Electrolyte imbalance, pulmonary, you need to correct all the, you need to address the precipitant. So we have a case 2, 52-year-old newly appointed minister noticed palpitation at rest and inability to complete his usual golf game and poor sleep, but attributes it to stress of the new office. So who can tell us what this poor sleep is all about? Poor sleep.
Raise your hand now and talk boldly or say it out. Highest who will laugh.
Please, I'm not hearing.
Possibly yes, autopnea, very possibly autopnea.
Or
yes.
PND.
Or PND. PND means that he's able to sleep first. Then occasionally he wakes up at night with some difficulty in breathing or coughing. Then later he can go back to sleep again. Autopnea, as soon as he lies down, bam, he sits up. Or he having to use 3-4 pillows. Okay.
Okay, never been told to have hypertension and diabetes. Had a checkup abroad 8 months ago and nothing significant found. On examination, looks well, not breathless. Leg does not look swollen, but mild dimple after pressing for 5 to 10 seconds. So does this patient have leg swelling?
Yes.
Okay, thank you. Then pulse rate on examination, pulse rate was 102, BP was 138/90. This is BP at home. Is the person hypertensive from what we have learned today?
Is the person hypertensive or not?
Okay.
Perfect.
Thank you. then JVP and ASAN not checked. But when they come to us, JVP and ASAN should be checked. That's why we are here, so we should check them. And then on normal, chest exam, chest was found to be normal. Chest exam was normal. So what do we think? So this patient needs lifestyle modification and to be reviewed again in 2 weeks. Okay, thank you. He has hypertension, needs hypertensive.
So let's vote now. We are voting. Those that say A, just lifestyle, and let him come back in 2 weeks. After all, he's stressed. It's his new office. Let him go and stay in Hilton for 2 weeks. Those for A, say A. Those for B, say B. Those that say it's just anxiety because his brother died, let's give him something to sleep and review again after the burial. C, say C. All of the above, say D. Okay, I don't know, Jare. I need to evaluate further. Say E. There are many.
So we don't know Jare, but we need to know Jare here. That's why we are here. Poll 2. Is it very possible that he has heart failure?
Awesome, awesome.
All right. Do we have any option C here? I don't know.
If you don't know, raise your hand. Still not clear to you. Okay, fantastic.
Okay, so we are all heart failure
specialists.
Please, we deserve a round of applause for ourselves. Please, let's appreciate ourselves. Okay, so how do we investigate heart failure? Okay, we do N-terminal proBNP. Like I told you, in heart failure, N-terminal proBNP is elevated. So they can help us in diagnosis when we are unsure and we need to follow up patients. In cases of coexisting COPD or patient presenting with dyspnea on exertion and we are not sure it's heart failure, so we can do this, and then this will help us to know whether it's heart failure or pulmonary disease. ECG is important to check abnormalities that can occur, abnormality that could have occurred, worsening or complicated heart failure. Like if we do ECG for the patient, can tell us what is the cause of the heart failure. Maybe we can see voltage criteria for LVH. We can see precipitants there on the ECG, maybe atrial fibrillation falter. And then it's good to know that a completely normal ECG is possible but rare. And ECG is mandatory. It must be done in all patients. So how many of us have ECG in our center? I'm sure we all do.
How many of you don't have ECG in your center?
Okay.
How many people is it locked up in the matron's office? Please, when you go back, you're going to be advocates, right? And tomorrow, please come early because we're going to start early on fire. If you miss that ECG lecture, you will not be able to do ACLS. So you need to come here on time. I know Nigerians don't like to come on time, but this one, bam, we'll go start. So again, if you are unsure, you have somebody that is having some breathlessness. If you don't still know what you are doing, just do this test, N-terminal proBNP. If it's elevated, very likely the person has heart failure. So last, you don't know what to do with N-terminal proBNP. It's a very simple test. It comes out in 30 minutes. I think there are a number of our partners at the back that sell this machine. I can see Dallas there. I can see one or two of them. So consider just popping into one of their booths and finding out. So if you just do the test, it comes out. If it's high, it's very likely.
Likely that it is heart failure.
But remember, heart failure is a clinical diagnosis. It is based on the patient's signs and symptoms that you make the diagnosis of heart failure. Remember, ECG is mandatory. Echo is mandatory. It is mandatory. Anything else, you are doing witchcraft. All right.
Okay, full blood count is necessary to know whether part of the precipitant is infection, anemia that can precipitate or worsen the heart failure. Chest X-ray is important to exclude pneumonia, fluid collection, and other diagnoses. Okay, so this is X-ray features of heart failure. There is an acronym for this. Who can tell us the acronym? I'm sure we have registrars among us.
Let's move past this one.
Okay, sir. All right. Okay. So investigating heart failure, thyroid function test, yes, should be considered, is recommended. Lipid profile to exclude other comorbidities, glycemic profile to exclude other comorbidities such as DM. Alter ECG in case of suspected arrhythmia, and other tests include D-dimer to rule out pulmonary embolism and troponin in case of suspected MI.
Again, for all patients that you suspect heart failure, you have diagnosed heart failure, TSH is absolutely critical. You must exclude thyroid abnormalities. Professor Anuma is here, so that let me just say it so that he will not catch me later. TSH is critical. Sometimes you are dealing with hypo or hyperthyroidism, which can also mimic heart failure. It can cause, it can precipitate, and sometimes it can mimic heart failure. It is critical. Except you have very severe financial constraints that you are trying to say, okay, which one can I manage? But as much as possible, if you want to manage people properly, and you've had them complain of some excessive tiredness, most people, their first and most important symptom is excessive tiredness on the background of hypertension. Please make sure that ECG is done, echo is done mandatorily, and where you can do it, do a TSH as well.
Thank you, sir. Okay, echocardiography is important, is invaluable and mandatory. What it helps us to get is the chamber size, the ejection fraction, to know whether there is any valvular abnormality, what motion abnormality in case of ischemic disease, and then to check the ejection fraction, most importantly, of the patient.
All right, let me just correct something. Hello? Hello? How many of us have seen an echo result before? Raise your hand if you have seen an echocardiogram result. Okay, great. A lot of people try to make diagnosis of heart failure using echo. That is wrong. Foul. That is wrong. 50% of patients with heart failure will have a normal ejection fraction. Another 50% will have a reduced ejection fraction. So if you use only ejection fraction, you are likely going to miss it. So sometimes our friends will just say, what's the ejection fraction? They say ejection fraction is 55. It's normal. Let's continue. No. If the person is still having those cardinal symptoms and you think you still need to do the BMP or other things and examine that person. Once you are seeing S3, you are seeing crepitations, you are seeing, even if the ejection fraction is normal, that person very likely has heart failure. So ejection fraction can be normal in heart failure. Okay? Thank you.
Thank you, sir. Thank you for buttressing that point. Normal ejection fraction does not rule out heart failure because we have an entity called heart failure with preserved ejection fraction. So when they come with those symptoms, you need to examine your patient very, very well. And like he has said, it's a clinical diagnosis. Thank you. I'm sure a lot of us will have seen patients, they say, and they said my ejection fraction is normal, and yet they're having leg swelling, difficulty in breathing, or toppling and the likes. That kind of patient should be commenced on anti-failure regimen. Thank you, sir. Okay, when we have a case of suspected heart failure, so the clinical symptoms, functional impairment, if everything is no, you do ECG, if everything is no, not likely having heart failure. But patient with pure cardiac disease, with risk factors, comorbidities, you do initial investigation on chest X-ray, and you saw evidence of ventricular function, assessment of, on chest X-ray, you saw features of heart failure, then you go ahead and do echocardiography, and you see assessment of, you assess ventricular function. That patient likely have heart failure. So other signs of congestion are also can be seen in patients when you examine patients. So you can go ahead and do some other tests like MRI, CT, and endocardial biopsy if need be in patients.
Okay, this is perhaps one of the most important slides, these two slides. In case you have been sleeping, oh yeah, wake up now. In case you have been thinking of Timbuktu, wake up, come back now. Okay, go to the next slide first before we go back to this slide.
Okay, which one?
The
this?
Forward slide, forward, after, forward,
This?
next.
This?
Okay.
Okay.
Typically, when we want to define heart failure, symptoms, investigation, and echo. Those three things, you need them. But we'll now go back. We have 4 steps, previous definition, previous slide. Good. So we have 4 steps when you want to check if a patient has heart failure or not. Hello? How many steps?
4 steps.
Thank you. Please, some people are awake with me. Good. Step number 1, history and examination. Does the person have, that's functional impairment means that they are getting tired easily. Is the person functionally impaired? Do they have leg swelling? Number 1 of that one. Do they have prior heart disease? Do they have risk? What are the risks for heart failure? MI, Abi? Hypertension, diabetes, Abi? Kidney failure. Do they have that? Yes. Are there other comorbidities that could have contributed to the heart failure? Yes. Are there signs of congestion, leg swelling, when the person lies down flat? If the answers to these questions are yes, go to the next step. If the answer is no, very likely you are almost not likely dealing with heart failure. So, but you go to the next step. So step one, either you pass or fail, you go to the next step. Next step, now you have come. We are going to do 4 things. That's investigation. So step 2 is what? Investigation. Step 2 is what? Investigations. Say with me so that you will not forget to. This,
Investigation.
guys, let me tell you something. Stuff has half-life. It means that you can know it now and it will just be degrading. This talking and writing helps to prolong the half-life of stuff. So that 6 months, 1 year. This one that I know now, I did not read it yesterday, is my talking that is keeping it. So when I ask you, you will answer so that you can increase your own stuff half-life. Some of you will never hear of heart failure again till you die, apart from today. Yes, now. So carry this one so that this one can carry you. God forbid your mother-in-law calls you from the village and you cannot diagnose, and you tell me, think I'm not the pain. So first step, history and examination. Second step, investigation. And investigations we are doing ECG, X-ray, BMP, and then other labs. BMP is very easy to do. Okay, if you don't have it in your center, you can send a sample down to Cardiocare, we'll get it done. 30 minutes, you get your results. If any of these things are suggestive, then we are on the road to heart failure. We'll go to the next one. Okay? Basic cut, high cut, appeal cut. Now we have gone to the next one. What's the next one? We need to assess how the heart is working. And we'll do an echo. The echo will tell us whether the heart is pumping well or relaxing well. Step number 3. Is music coming from here? This party is good though. And number 4, diagnostic information, additional one. Cardiac cath, radionuclide. We don't do all of these things in Nigeria except cardiac cath, which we do in Cardiocare. The remaining, we're not quite doing them regularly. So these are the 4 steps. If your answer to this, at least the first 3 are no, 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 the person doesn't have heart failure. If your answer to the first 3 are yes, 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 then you are dealing with heart failure. Do we understand that? Good. So back to that case of the minister, newly appointed, blood pressure 138/98. He can no longer complete his game of golf, right? So then when we press the leg for some time, we now notice there was swelling, Abi. So step 1, did he pass, yes or no? Yes, so we move to that side. Then we go on, we do his BMP. BMP was elevated. Chest X-ray gave some suggestive features. And ECG showed some atrial fibrillation. Yes or no? Yes, so we move to the next one. Then we'll do his echo. Whether the EF is positive, is low or high, does not matter. It is just to help us in characterizing the heart failure and to know if there are other things that we need to treat. And then we go on. We don't even need to do number 4. Then we say that minister, even though he's very powerful, has what?
Heart failure.
Excuse me, sir. I'm very sorry. I know you went to abroad and you did. You know they say he did abroad, Abi? Anybody that does even MP abroad, they'll say they've done check-up abroad. Don't follow what we are saying today. Abroad is abroad. Niger is Niger. We have checked it and we are graduates of ACS 2025. Say yes, Abi? You did it, you came, you had the certificate, you passed the test, and you are graduate. So you are sure that this person has what? Heart failure. And this is, you must not forget. So the next slide. If you were asleep with this heart, you must remember. So next slide is this heart failure syndrome. We add to our lab, plus or minus our echo, and we say the person has heart failure. Please, a lot of patients are being missed with heart failure. Some of them are coming to your clinic, you're just giving them their refill drugs. Some are coming to the pharmacy and you're telling them to just pick up the drug and continue. No. The moment they start having, even if it's small leg swelling, don't say I'm not the pain. Investigate, evaluate, and go on. If you do not hear anything, at least you hear this one. Wake that man up. Aha! What's heart failure? Great. So now that you're woken up, these 3 things, Abi, fantastic. I hope that's very clear, isn't it? Very, very clear. I don't understand. Go over it again. Anybody? I should go over it again.
We should go
the
over
previous
it
slide.
again.
Okay, go back to the previous slide. This previous slide is just saying, talk to the person and examine the person. If you find features of occasional, the man say he has moved his bedroom from terrace, third floor to first floor. He has changed his flat. He has changed his office. He can no longer walk far. He will have to stop and rest a little bit. First thing. He has some swelling or not. Second thing. We now go to the lab. We now did our BMP and our ECG. We found something. By the time we add that one, we'll say this person has heart failure. Then we can now do our echo and other tests. The echo now helps us to characterize it, and we say the person has heart failure. That treatment, if you don't treat them well, up to half of them will die within 1 year. Hello? 1 in 2 within 1 year will die. This is why we are handling this topic. That life expectancy in Nigeria is not by mistake. Is because we have not taken these hyper things and brought them down to the nurses, to the doctors, to the pharmacists giving the drugs. Everybody must be a healthcare provider. Everybody must understand the appropriate thing, appropriate treatment. Sometimes we prescribe drug to the person in the pharmacy, and the pharmacist will say, "This drug are too many now. Who gave you this drug? Reduce it." Those pharmacists, any pharmacist like that here, just keep your hand down or don't confess. Because we'll mob you. Those who gave you this drug? This drug is not needed. Let's reduce it for you. We put a stent for somebody. Gave him aspirin and clopidogrel, which they must take 2 antiplatelets. One pharmacist told him, "Now why are you taking 2 of them? They're doing the same thing. Remove it." The man came back, the stent has blocked. I'm telling you. So the reason for this is to make sure that this is everybody's knowledge. It's not for specialists. It's not for those in cardiology clinic. It's for everybody. This is basic medicine. So we can all make diagnosis of heart failure now. Great. Next slide.
So how do we classify heart failure? Like I said, we have an entity called heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. Preserved ejection fraction is when the ejection fraction is greater than 50%, while reduced ejection fraction is when it's less than 40%, and mildly reduced when ejection fraction is between 41 to 49. So it's good to still reiterate that normal ejection fraction does not rule out heart failure. So we have a case here. Mr. H.A., 59-year-old known patient with heart failure diagnosed about 8 years ago, presented with worsening breathlessness with associated orthopnea, PND, and worsening leg swelling. On examination, it was found in respiratory distress, afebrile, not dehydrated, bilateral painting pillar edema up to the shin. Cardiovascular exam, it was tachycardic with pulse rate of 112, regular small volume, BP 112/78. I asked first, second, and third heart sound. Echo done showed dilated cardiac chamber, global hypokinesia, ejection fraction of 26%. So what class of heart failure is this, please? I just said it. I didn't hear you, please. So option A, this is heart failure with preserved ejection fraction. This is NYHA class 4.
Did we do NYHA class? Yeah, we've done NYHA class.
Oh, we know which class. Okay, like you just said.
Okay, so there are 4 classes of heart failure NYHA class. Can we write?
Oh,
Can we write?
That's the next slide.
Yes. Can we write? Let us talk it, then they'll see the slide.
Okay. Yes.
Sometimes when they see slide, they know they follow them again.
Okay.
Class 4, the person is breathless at rest. They are sitting down. NYHA class 4. Can we write that one? This is one of the most powerful ways to classify heart failure. Class 4, the person is breathless while seated.
Trust.
Class 3, the person is not breathless at rest, but when they do something small, they get breathless. If they walk from here to that second screen now, on the straight ground, if they bath, they will get breathless. If they do Jumat, they will get breathless. Class 3. Class 2, they can do a lot of things. They can almost climb 1 flight of stairs before they start getting breathless. Okay? Class 2. Class 1 is almost like most of us are not doing exercise. They can climb 1 or 2 and no issues. Do we understand? Should I go over it again? Class 4. Class 4 is what? Breathless at rest. They are sitting down and they are panting. Class 3. Breathless, mild exertion. Less than ordinary activity causes them to be breathless. Class 2. Breathlessness or moderate exertion. They need to climb up a flight of stairs. They need to walk from here, maybe to that gate, before they start feeling breathless. Class 1, they need to walk from here, maybe to that mosque or to Wike's office, before they start feeling breathless. Okay, like most of us, Abi? All right. So these are the 4 classes, NYHA class. So that patient in this thing, can we go on to that patient? In this patient, worsening breathlessness, when we saw him, is that breathlessness? Yes, worsening breathlessness. Autopnea, just worsening breathlessness. So we did not see how much worsening. So if he is breathless anytime he goes to the bathroom, he has to sit down in the bathroom first before he can come back. What would that be? Class what? 3. 4, he's breathless all through. He's breathless now. Before he gets to the bathroom, he's breathless. In fact, some of them are they just wear their clothes. They can't even wear their shirts. Even at rest, they are breathless, Abi. So class 3, they are not breathless at rest, they are fine. But when they just move from here to that chair, that's class 3. You see those ones, they look fine. But when you tell them to go upstairs, they look at the staircase. In fact, their heart starts paining them just looking at the staircase. Some of you are already feeling like that. If we say let's run around, you start, in fact, you just say, I beg. So you are close to class 2 or 3, Abi. Then class 2, 1 staircase or thereabouts. Class 1, you need to do a lot before they feel breathless, just like most of us. Good. I hope we understand that. Perfect. All right, let's go to the next one. Why is it important to do this NYK class? Can we go to the next slide, please? Why is it important to do this NYK next slide? Why is it important to do this NYK class? Those in class 4 sometimes have as high as 60 to 70% mortality within 1 year, irrespective of treatment. So if you miss it and you don't get a specialist involved and you don't get correct drugs, they are almost definitely going to die. Almost definitely. Which is why you are here. You are here. We have been doing this for a number of years, and we have many alumni and ambassadors all around. And when they come back, they tell us, I did CPR today, the patient is alive. You need to see the excitement in their ears, in their eyes. I thought CPR never worked. I thought we were just doing it so that the relatives would say we tried. Same thing now. People are also going to say, I was able to diagnose heart failure. This is the basic things. But after diagnosing, you need to classify it. And that's the classification you're talking about because it affects long-term outcome. Yeah.
We have another case.
We have another case. Worsening shortness of breath, swelling the legs, hypertension, diabetes, previous stroke. What kind of risk is this? High, very high, extremely high. Which one? Extremely high, Abi. Because he has a CVD and he has diabetes on top. Diabetes is a very bad disease. On his own, now war. Then we now added it to previous stroke. Then he now has hypertension. Then he's now short of breath. What will his LDL target be now? 40, less than 40, fantastic. He's now very high risk. In this kind of patient, 140/96, is that, will we manage it? Let him just manage, let him rest a bit. He must be treated. Thank you so much. I'm so happy with that no. God bless those people that say no. The people that are still thinking, sorry. All right. Good. So, what should we do? Review in 2 weeks. His problems are only hypertension and diabetes. Let's give him medications for that alone. He should be admitted, investigated, and treatment should be commenced immediately. What he needs is rest. He will be fine. Don't worry, sir. Okay, all of the above. No, thank you very much. At least. We don't need the Supreme Court in this matter, Abi. Yes, the vote is clear. Thank you so much. All right, next. No. He likely has heart failure. Yes. Awesome. Fantastic. We are there. Pole 3. Echo is necessary in this patient. Are you sure? He should be reassured. He stepped on juju. He might poison now. One of my staff, not another staff, he has worked in the hospital for several years, said he needs to go to the village to take his father, that he matched poison. That they have done all the tests, everything is looking fine. And he went to. They spent 2 weeks. Understand? You understand there, Abi? We all understand, Abi? Later I came and said the father is fine. I don't know what they did. They said the father is fine. I don't know. I will not ask. I have not asked again what happened. He left us. All right, so no need to investigate him. No. Only A is correct. None of the above. I don't know, Jare. Who still doesn't know? You know, Abi? Fantastic. Right. Fantastic. All right, let's go.
Okay, we have discussed the case. So how do we treat heart failure? Okay, we counsel and educate patients on the disease, on the diagnosis, and then counsel them on the need for compliance. So for treatment, the treatment is targeted at blocking the neurohormonal system, and this is the basis of the pharmacotherapy in heart failure patients. Then we treat the etiology and the precipitant. It's good to identify the etiology and the precipitant. It could be infection, anemia, it could be MIP, and all. Then we optimize their cardiovascular risk and comorbidity. If they are diabetic, we give anti-diabetic drug. If they have dyslipidemia statins, if they have stroke, we know the target now for the healthier. Then we assess the need for intracardial devices. So we do this here. You can refer your patient at any time. Then there is a role of multidisciplinary follow-up. This is also good in ensuring compliance in patients and to transit them from index hospitalization to to treatment at home. Okay. So for counseling of patients and family, it should be a continuous thing. Follow-up, adherence and follow-up. Need for procedure should be assessed at every point, at every contact with them. We specialist review and support groups. Okay, for the education on living with heart failure, medication adherence is key. You need to tell them that this is a lifelong, it's a chronic disease. They need to be on their medication all the time. Some patients can actually tell them that, doctor, I'm tired, I just decided to just stop. So we should tell them that they don't have to stop. They should just continue their medication and then be regular on clinic follow-up. In case of fluid retention, we need to tell them to limit fluid intake, low salt diet. They should have continuous daily weighing. In case they notice any weight gain, they should present to the hospital, meaning that they are retaining fluid. Then psychological coping, they should be able to recognize alarm signs, worsening dyspnea, increased weight gain, reduced urinary output. When they have, some of them do have their SpO2. When they are noting desaturation, they should present to the hospital. It's always good to tell them these alarm signs, because when they are able to pick it, they present to the hospital even before their clinic appointment date. Then you should caution them on drugs. Some of them on top of this failure, they can be taking alcohol. Some of them can be taking local medicine. So we need to warn them about some intake of local herbs.
As you can see, education. Our people have so much wrong education. The most important step in hypertension, in diabetes, in heart failure is education. Don't just give them drugs and go and pick the drugs. No. You must spend 5, 10, 15 minutes. Don't just educate them, educate their families. Don't educate their families. Prophesy to them that when you leave this place, somebody is going to tell you to come and take one grass. Because it will happen. You need to tell them so that they are expecting it. Otherwise, they leave your place and they go and start mixing things together. Please, education. And the first education starts where? You. If you don't know enough about it, you cannot answer their questions. If you cannot answer their questions, they will not trust you. Okay, and they will not trust the medications. So education. So these are the things you're educating them on. Their drugs, lifestyle, drugs to avoid, NSAIDs, ibuprofen, Feldin. Please, you yourself, don't prescribe it. Say, no, it's just small, it's having arthritis. No. Feldin, what again? Naproxen, Ibex, all those kind of things. please, there are no in heart failure. Absolute no. It will worsen it immediately. So you need to warn the patient, and as well you need to educate yourself about it.
Smoking cessation, alcohol cessation is important. Okay, I think we have mentioned this.
So you can see our 8 steps of treatment, Abi. So first is to counsel and educate. Second is the treatment of the hormonal things. So you can see heart failure has entered endocrinology. That's why we brought Professor Anuma. Because now we are turning to say it's a hormonal disease. Most of the treatment we are doing is hormonal. So we are endocardiology. In fact, we've taken one of their diabetes drugs. And you will see it in the list. And then we now go to the, so we are on step 2. We are finished counseling. Now we are going to step 2 to neurohormonal treatment.
Okay, neurohormonal treatment. So that's where we give the likes of spironolactone.
Next slide.
Okay, all right. Okay, we have 5 pillars of heart failure medication. We have, like we said, this neurohormonal thing. So the first is, we have A, B, C, D. Please, can we echo A, B, C, D, E? Okay, so A is what? ACI, hair, B, or honey. B is what? C is what? D is what?
Some people are just saying.
D is what? DM like SG healthy 2. So I'm sure we know this medication, that pagliflozin and pagliflozin. Some patients have come to me that they said they should stop it, that they are not diabetic. Please don't do that now, as from today.
Please.
Studies have shown that it improves mortality and reduces hospitalization. So it's one of the 5 pillars of heart failure management.
It's very important. Nurses that are here, thank God your director of education is here too. Please. Sometimes the patient will leave the doctor, and patients trust nurses more. I mean, nurses. They trust nurses more than us. They will go to the nurse and say, nurse, the nurse will say, Sam? No. This one is not meant for that one. Please. Things have changed, and drugs are critical. The change in mortality for those that are on this drug and those that are not on this drug is massive. So these pillars, you can see it's holding it up, are critical in heart failure. The last one, diuretics and some extras who might be, but these other ones, hey, we must. Corticoid and mineralocorticoid receptor antagonists, that's spironolactone or eplerenone. Okay, so A, B, C, D, E. A. Now this A is ACE, ARB, or R9. Never give them together. If you give them together, what you call, the person will die, oh. The person will die, oh. It's one of them. Then beta blockers. Don't give, the person is overloaded with fluid or, so much edema. You have to take time and introduce it. Of course, specialists have to come in at that point. And then spironolactone and lactone. If you, especially this A, B, C, D, people that are not on it will not live as long. These drugs change mortality. If you're only giving furosemide, digoxin, and Sloke, you did not go to a good school. Or let me not blame your school. Blame somebody, Sha. Yeah, but now you are hearing it. The person must be, that furosemide will help them feel better a little bit, but it will not change whether they will die or not. They will still die in 1 year. They may come and praise you, but collect that praise more. Because you must make sure they must be on all the pillars, otherwise the house will fall down. Is that clear? Is that clear, please? No, we should go over it again.
We should go over it.
All right, Dr. Taiwo, maybe go over it. Maybe they not hear
Okay, there are 5 pillars of heart failure medication. A, B, C, D, and E. The diuretics, DE, the diuretics and extra, is for symptoms relief. Most times they come loaded, pedal swelling and all. So it's just for symptoms relief. But the A, B, C, D, the AC, ACI, ARB, honey, beta blocker, corticoid receptor antagonist, and the DM light, they are main pillars of the heart failure management. So when patients are not volume overloaded, you may not give the diuretics, but these 4, they are very important. Like we said, it is a neurohormonal thing. So the ACI is to block the RAS, the beta blocker is to block the sympathetic drive, the corticoid receptor antagonist is to also block the MRA system, and then the SGLT2. Studies have shown that patients that are on these 4 medications, they do well more than others. Studies have shown that improve mortality, reduce hospitalization. So the patient should be on it. If you are, we should know this, that as we are leaving this place, we should remember the 5 pillars, please. Gone are the days of giving only furosemide. Furosemide is for symptoms relief. Okay, so like I said, the ARB, the examples are Vasartan, Candesartan. We can give any of the ARBs, but we don't give the ARB and ACI together. And when you are giving the high, and I'm sure we know them in our practice, the Uperio, I'm sure, has anybody or anyone of us seen the Uperio before? Okay, Uperio, Sacubitril, Vasartan. So when you are giving patient that is already on ACI or ARBs, you need to ensure 36 to 48 hours washout before changing to ACI. And then 24 hours for ARB. Never combine these drugs. So the beta blocker that we can use are bisoprolol, carvedilol, metoprolol, succinate, where they are not fluid congested. Spironolactone, Plerenone, and then empagliflozin, DAPA, and then the furosemide if they are volume overloaded. Okay. Okay, it's the same thing. Okay, so you can see the reduction here. I love this, this diagram. We can see the reduction. When you start from honey, 25% reduction. We had beta blocker, you have 16%. You had MRA, 16%. You had SGLT2. So overall cumulative, you have 10% reduction in mortality. So it's good to know that these drugs, the 4 pillars, they are very, very, very important in the management of heart failure. And if you don't have it in your center, like the Annie, we have it in Cardiocare. Please, you can just refer your patients. We give them.
Now, Novartis has a stand at the back, so if you have a time, you can go there. Uperio is, the branded is quite expensive. There's generic. Whatever the case, branded or generic, make sure your patient is getting something. Please. If they cannot even afford it, make sure you are prescribing for them so that when they can afford it, they take what they can. Okay, we are hoping that some of you to get on the NHIS list so that you can also be part of the NHIS very soon. Good. So I think we can now move faster.
Okay, sir. For hypertension, we use the same drug like ARB to treat the hypertension. For ischemic heart disease, if they require PCI as stent, refer them to us. For valvular disease, we also do surgery. For thyroid dysfunction, medication. So finding and treating the precipitant, if it's an arrhythmia, that is why ECG is key. If there is an arrhythmia, you need to treat the arrhythmia, because if you don't take care of the arrhythmia, the patient will not get better. If it's an infection, you got to treat the infection. Free valve, that's why your furosemide and the diuretic comes in. If there is electrolyte arrangement, we need to control that. And if there is uncontrolled hypertension, we need to optimize the hypertension and treat to target, like my colleague, Dr. Inu, has mentioned earlier. Okay, I think we have talked about this. So our blood pressure target is less than 130/80. We know the target for the cholesterol. I don't want to waste time on all this. Then comorbidities, if they have COPD, some of them may require medication for their COPD. If it's CKD, some of them may require dialysis. If there is diabetes, you give the anti-diabetic drug. There's psychosocial support in case of depression. So the studies have shown that a lot of them have depression, so we can involve clinical psychologists. We do that in our heart failure support group. Okay, assess for need for device therapy. If despite good treatment for up to 6 to 8 weeks and your patient is not getting better, it's time to consider device. All patients with ejection fraction of less than 30 to 40 and NYHA class, we need device. So patients with ejection fraction of less than 30 to 40 that has been on treatment for this period with normal QRS duration, patients will need ICD. So ICD is to prevent sudden cardiac death. And their patient is widening KRS. Widening KRS is an evidence of left ventricular desynchrony. So it's typified on ECG as widening QRS. So if you see such patients will need cardiac resynchronization therapy. We all have it in Cardiocare.
Again, everybody with ejection fraction less than 35%. After you start your treatment, ejection fraction is likely to improve sometimes. So after 2 months, repeat that echo. If the ejection fraction remains low, please recommend them for an ICD. It is to prevent sudden death. This is international standard. So they get an ICD. The ICD is just a machine that will be there recording and checking their ECG. And anytime they have one of those arrhythms, which we'll teach tomorrow, that wants to stop their heart, the ICD will treat it. The ICD will act like a pacemaker. It can deliver a shock so that the person can be alive. We have quite a number of patients with it. And when we interrogate and check the device, truly the patients will have died. They will have died 1 year ago, 6 months, if not for the ICD. So please consider this standard of care for the patients that can afford it.
All patients that survive cardiac arrest, you have a device. Like the first case I posted, does that patient require a device? So do we remember the first case?
He had a cardiac arrest.
He had a cardiac arrest, so the patient will benefit for device therapy. Poor patients that have high ventricular tachycardia burden on OTA should have a device.
You're hungry, Abi. Food is coming. Food is coming. People's assimilation is reducing. Please, Mr. Emmanuel, can we start this thing so that then we'll now take a message from the medical and nursing and midwifery council of Nigeria. Okay. Please.
All right. This is just a summary of what we have discussed. The 5 pillars. Then patients with left ejection fraction of less than 30, 5% patients should have ICD, and then patients with ejection fraction of less than 30% with QRS of greater than 30 should have CRT-D or P. Okay, I think this is okay. All right. Okay. Multidisciplinary follow-up. Clinical cardiologists, social workers, primary care provider. And thank God we are launching a new society today, so all of us will be in this. So how do we follow up our patients? At each contact with our patient on follow-up, clinical assessment is necessary to examine them, to ask them about their symptoms, to assess them, the NYHA class, to check their medication if they are adherent, any side effects, you ask them. We can do blood tests as needed, and then we cancel them on their medication management. So how often do we do this? For patients, every 1 to 2 weeks for 3 to 6 months until stable. Then after stabilization, we can do every 2 to 3 months. Additional follow-up, you can do remote monitoring, then caregiver support and education. For advanced heart failure, this is also another subset. We see them a lot. So for these patients with advanced heart failure, they need more frequent visits, at least every 1 to 3 weeks, and then closer monitoring of their weight. Some of them, or most of them, they are directly dependent. So we need to have a closer monitoring for them, and then consideration of device if they come to us. Okay, we have psychosocial support in our Cardiocare. We have heart failure support group that was started last year, January. And the meeting usually every first Saturday of every month. It's a free complimentary program meeting for heart failure patients, their caregivers. It's facilitated by clinical cardiologists, dietitians, heart failure nurses, doctors, psychotherapists. So you can refer your patient to us. They can freely join the support group meeting. It's free. They don't have to pay. Okay, okay, we have a case of acute heart failure. Mr. UC has heart failure with reduced ejection fraction, with symptoms consistent with NYHA class 4.
What's NYHA class 4?
Dyspnea
at rest. Perfect.
Okay. Chest X-ray showed cardiomegaly, pulmonary congestion. Echo showed left ventricular ejection fraction of 20%. So this is heart failure with what?
Reduced, Abby. Yes, reduced ejection fraction. BMP 2,500. Normal BMP is normally 300 and below. Okay, next.
Okay, so what do you think we should do for this patient? We should nurse in cardiac position?
Yeah.
We should give oxygen therapy?
Yeah.
Diuretics should be commenced, e.g. furosemide.
Yes.
ARBs or honey should be commenced.
Yes.
Aldosterone antagonists should be commenced.
Yes.
All of the above are correct?
Yes.
Okay, so we are heart failure specialists. Please, let's clap for ourselves. Oh.
Yes, so yes.
We are trying. Okay. All right, thank you. Okay. So for this patient now with EF of less than 40, do we consider device for the patient? Okay, thank you. All right. Okay, we should monitor vital signs and oxygen saturation. We are not sure. How many of us are not sure? Okay, we have discussed. When is admission needed? Patient can present with acute heart failure. This refers to rapid or gradual onset of symptoms warranting urgent medical attention. So they can present with acute decompensated heart failure. Patients already diagnosed heart failure. They can present in acute pulmonary edema. They can present in cardiogenic shock. So this is what to do when they come, especially in case of cardiogenic shock or respiratory failure. We can give pharmacological support. Inotropes, we can give ventilatory support or mechanical support. We have mechanical support in our center, left ventricular assisted device, tandem heart. So it's good to identify the etiology. So please, let's echo this, please. CHAMPIT. So, CHAMPIT. Identification of acute etiology. So acute etiology can be acute coronary syndrome, hypertensive emergency, arrhythmia, mechanical cause, pulmonary embolism, infection, or tamponade. Okay, so management of patients with acute decompensated heart failure. So patients present with congested food overload, hypoperfusion. So what do we do? Food overload with hypoperfusion. Anyway, let me just run over it. Patients should be given loop diuretics and consider inotropes. This is class 2B recommendation that it should be considered. And then we can also consider vasopressors in the patient. And then when patient is still having persistent hypoperfusion or organ damage, we consider mechanical support like a left-assisted ventricular device or intra-aortic balloon pump. Okay. So for management of acute heart failure, you know that we need to manage, put patient in, nurse patient in cardiac position. We give oxygen. Oxygen therapy is recommended in patients when the SpO2 is less than 90%. We give diuretics in the like of furosemide, like I said, is for symptoms relief. And then we can consider inotropes when the patient is hypotensive. Okay. So for vasopressors, we can give
let's leave this one.
Okay.
So it's getting serious.
Okay.
Okay, for all the people with acute heart failure, NYK class 4, please bring in a specialist early. Bring in a specialist early. What I need for you to understand first is to identify it. Is to start the loop diuretics. Is to nurse them properly. They should not lie flat. They should lie, propped up. We typically like 45 degrees or even 50 degrees. If the blood pressure is too low, they need ICU. This is not the one you will manage. This one pass your level. But the important thing is to recognize it, not to be saying it's pneumonia, not to be saying just give oxygen, to recognize it that heart failure, acute heart failure, mortality rates can be as high as 80% within that admission, can be very high. So please, at that point in time, you should know, let's not go too much detail. Let some people now say, okay, now this is what I will be doing. Not like that. This is just an introduction to it. We can use these 2 days to teach only heart failure. For all the topics, we can use the whole 2 days to teach only all the topics. So this is an introduction for you to be able to recognize, treat, and follow up appropriately for them. Okay?
Okay, thank you, sir. Okay, in conclusion, heart failure is a major health challenge. Hypertensive heart disease is still the leading cause. Accurate diagnosis through history, physical examination, ECG, echo, and biomarkers. Guideline-directed medical therapy and device therapy when needed is key in the management. Follow-up, patient education and support can improve outcomes of patients with heart failure. Thank you.